All right, there we go. All right, good morning. If you're dialing via telephone, Google Meets have muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DUR board members reserve questions until the end of presentations or ask in the Google Meet chat. For those providing public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. And I would ask to do it at least 48 hours before the meeting so I can have time to add to the agenda any public comments. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process moving forward. And thank you very much. I see Dr. Weinstein is with us today. Thank you so much for all that you do, and I turn the time over to you now.
Thank you. I echo my welcome. As we said, Happy New Year to all of you. And again, thank you for your participation today. This is our January the 8th, 2026 first DURB board meeting of the year. Not sure if we have any introductions this morning, Luis, or no?
No, not that I know of.
Okay, then I think our first order of business, hope that you've all had the opportunity to look at the minutes of the last meeting. If we have any comments or suggestions, we'll take those now. If not, take a motion to approve the minutes as written.
Motion to approve.
Thank you. Do we have a second?
I can second.
Thank you. All in favor? Say aye.
Aye.
And I believe I'll abstain because I was not in attendance at the December meeting. And thank you for that. Next up on the agenda, we have some updates, if there are, on the prior authorizations work. Luis, do we have anything for that today?
Oh, yes. I just wanted to report that all the prior authorization forms that were reviewed in December have been updated to our website. And also the criteria for the Wegovy for the treatment of MASH has been added to our umbrella PA called GLP-1 medications for weight loss and other indications. So that's where those criteria are found now. But yes, that's all the updates I have for that.
Thank you. I know that's, again, been extensive work and appreciate everybody's attention to that. I think first up on our discussion considerations for today is treatment with Botox and the CGRP antagonist. So I'll turn it over to Monet. Thank you.
All right, thank you so much. Good morning, everyone. The goal of today's presentation is to review the evidence and guideline recommendations for the combination use of Botox with a prophylactic calcitonin gene-related peptide, or CGRP, antagonist for headache or migraine prevention in patients diagnosed with chronic migraine. Chronic migraine is a highly disabling neurological disorder that affects over 4 million adults in the U.S., predominantly women. The International Classification of Headache Disorders, 3rd edition, provides the criteria for the diagnosis and classification of migraine. The diagnostic criteria for chronic migraine requires a headache frequency of 15 or more days per month for more than 3 months, with migraine features on at least 8 of those days. The term episodic migraine is generally used to describe headache or migraine occurring at a lower frequency than in chronic migraine. Although the 15 or more headache day threshold provides a practical framework for classifying patients based on disease burden, it has been criticized as an arbitrary threshold by some experts and may poorly reflect and oversimplify the migraine clinical spectrum. Moreover, the diagnosis of chronic migraine seems intended to reflect the patient's baseline disease state prior to the initiation of preventative treatment, although there is variability in the manner chronic and episodic migraine are used in the medical literature. Because these terms seem most useful for classifying patients according to their basal disease burden independent of prophylaxis medication, rather than their headache frequency while on treatment, I'll use these terms in this context throughout the presentation. According to this perspective, it may be inappropriate to consider patients diagnosed with chronic migraine to have their condition resolved and reclassified as episodic migraine if they are dependent on preventative treatment to achieve headache frequency levels below 15 days per month. Two distinct migraine prophylactic options for chronic migraine include onabotulinum toxin A, or Botox, which I'll refer to as ONA-A, and prophylactic CGRP antagonists, among others. ONA-A was the first migraine prophylaxis medication approved specifically for adults with chronic migraine in 2010. Since then, 5 CGRP antagonists have been approved for headache or migraine prophylaxis in adults with chronic migraine or episodic migraine. ONA-A requires in-office intramuscular injections every 12 weeks, whereas most prophylactic CGRP antagonists are administered subcutaneously on a monthly or quarterly basis. The exceptions are atogepant given orally daily and eptinizumab given intravenously every 3 months. Goals of migraine prophylaxis include reducing the frequency, intensity, and duration of attacks, as well as migraine-related disability. The decision to start preventative therapy should be individualized and can generally be considered for patients who have either 4 or more monthly headache days of moderate or severe intensity that do not respond to acute treatments, or any number of monthly headache days with insufficient migraine relief from optimized acute treatments for frequent use of acute medications, and or with impacts on quality of life, especially when perceived as severe, despite the use of acute medication or trigger management strategies. For recommendations regarding the combination use of ONA-A with a CGRP antagonist for migraine prophylaxis, we reviewed 3 recently published guidelines, one each from the Department of Veterans Affairs, Department of Defense, or VA/DoD, the International Headache Society, or IHS, the Canadian Headache Society, or CHS. We also reviewed recent position statements from the American Headache Society, or AHS, and IHS. Reviewed guidelines generally recommend CGRP antagonists and ONA-A for migraine prevention in patients with chronic migraine. Both the AHS and CHS recognize them as first-line options. The AHS no longer recommends that the initiation of CGRP antagonists require prior failure of other drug classes for migraine prevention, in contrast to its 2021 consensus statement. In addition to these agents, topiramate is consistently recommended across reviewed guidelines for patients with chronic migraine, and most guidelines also recommend propranolol. Notably, the CHS strongly recommends CGRP antagonists and ONA-A with high-quality evidence, while topiramate and propranolol are recommended with lower quality of evidence in chronic migraine. Differences exist between guidelines regarding other preventative agents with an evidence base primarily in episodic migraine. For instance, according to the AHS, candesartan, certain antidepressants, or valproate can also be considered for patients with chronic migraine, whereas the VA/DoD and CHS generally do not provide recommendations for the use of such agents because robust studies of these agents in chronic migraine are lacking. There is not a standard definition for what constitutes as effective preventative therapy or a treatment response, but traditionally has been considered as at least a 50% reduction in headache frequency, or in the setting of chronic migraine, at least a 30% reduction. However, even with effective prophylactic monotherapy by these definitions, some patients, especially those with a high baseline migraine frequency, such as in chronic migraine, may experience substantial residual migraine burden and disability despite having a positive treatment response. Therefore, guidelines also recommend evaluating meaningful improvement in migraine-related disability using patient-reported measures. Additionally, in a 2025 position statement, the IHS supports shifting away from percentage-based measures of response to patient-centered goals in clinical practice, with the most ideal proposed goal for preventative treatment being complete elimination of disabling migraine days or moderate to severe headache days. However, because complete elimination may be unrealistic for some patients with the current medication options, the IHS position statement considers optimal control of migraine to be when the patient's symptoms are reduced to fewer than 4 days per month with migraine or moderate to severe headache, a goal that potentially warrants combination prophylactic therapy. The 2024 guidelines from the CHS and IHS provide recommendations on dual prophylactic therapy based on expert consensus. Other reviewed guidelines either did not address this topic or was neither for or against the use of combination therapy for headache prevention due to insufficient evidence at that time. Based on observational evidence, guidelines recommend 1, adding ONA-A to a prophylactic CGRP antagonist for patients diagnosed with chronic migraine who have clinically meaningful residual migraine burden despite having a positive response to CGRP monotherapy, or 2, considering concomitant use of ONA-A and a prophylactic CGRP antagonist for refractory migraine, defined as residual symptoms that cause significant interference in functional abilities or quality of life despite the use of acute and preventative treatment. Additionally, a 2021 AHS consensus statement mentioned that dual therapy with a CGRP monoclonal antibody plus ONA-A is probably effective for migraine prevention in the setting of chronic migraine. Notably, ONA-A and CGRP antagonists target different physiological pathways, allowing for concurrent use to potentially have an additive or synergistic effect. Now I will discuss the results of our targeted literature search conducted in July 2025 for available published evidence of combination therapy with ONA-A plus a prophylactic CGRP antagonist for migraine prevention. The available published evidence on the use of ONA-A in combination with a prophylactic CGRP antagonist is limited to uncontrolled, non-randomized observational studies and single-arm pre-post studies. Of the 13 identified studies, 4 were observational cohort studies, which also included intrapatient pre-post outcomes, and 9 were single-arm pre-post studies with intrapatient comparisons of outcomes to baseline, either to a baseline without prophylaxis treatment or to a baseline while on treatment with ONA-A or a CGRP antagonist individually. All identified studies were among populations with chronic migraine, either based on diagnosis or baseline monthly migraine days before ONA-A or CGRP antagonist therapy. Overall, most single-arm studies evaluated the addition of a CGRP monoclonal antibody to ONA-A therapy. Based on the systematic reviews and guidelines we reviewed, along with our targeted literature search, we did not find any relevant randomized control trials. All reviewed intrapatient pre-post comparisons in 2 inter-cohort studies suggest that ONA-A plus a prophylactic CGRP antagonist confers an additive benefit, particularly with respect to reduction in migraine or headache frequency compared to ONA-A or CGRP antagonist therapy individually. These findings are consistent with a 2022 systematic review and meta-analysis that found dual therapy with ONA-A and a CGRP monoclonal antibody significantly reduced mean monthly headache days by 2.7 after 3 months of treatment compared to ONA-A alone. One identified retrospective cohort study showed an improvement in the primary outcome of migraine-related disability in a cohort treated with ONA-A plus Arinyumab compared to a cohort that switched from ONA-A to Arinyumab. Improvements in headache and migraine frequency were also numerically greater with combination therapy than with Arinyumab. Another retrospective cohort study also showed that combination therapy with ONA-A plus a CGRP monoclonal antibody significantly improved monthly migraine days compared to either agent alone in a comparison between separate cohorts. Two identified cohort studies found no significant differences in response rate or reduction in headache frequency between cohorts of patients on combination therapy compared to those who are on CGRP monoclonal antibody monotherapy or who switched from ONA-A to a CGRP monoclonal antibody. However, due to major methodological issues, the results do not seem extrapolatable to the entire population eligible for combination therapy. Both studies had obvious or unconsidered treatment assignment bias, creating non-matched comparison groups with respect to their propensity to respond to ONA-A. Furthermore, uncontrolled confounding factors such as allowance for additional prophylactic agents or changes in those therapies also created internal validity concerns. Overall, combination therapy with ONA-A plus a CGRP antagonist was generally well tolerated across the 8 studies that reported safety outcomes. The most frequently reported adverse events were consistent with the known safety profiles of each individual agent, with constipation most commonly observed. Serious adverse events were rare and most reported events were mild. Across the studies, discontinuation rates due to adverse events or tolerability was generally low for both ONA-A and CGRP antagonists. All reviewed products are contraindicated in patients with a history of hypersensitivity reactions to the active ingredient or any excipients. For ONA-A, this includes hypersensitivity to any botulinum toxin product. ONA-A is also contraindicated in patients with an active infection at the intended injection site and has other contraindications related to its other approved uses. All reviewed products carry a warning for potential hypersensitivity reactions, requiring discontinuation if they occur. Each reviewed CGRP antagonist carries a warning for the potential development of new onset or worsening of pre-existing hypertension or Raynaud's phenomenon. This slide shows the unique warnings among the reviewed products. Arenumab has a unique warning for potential constipation with serious complications. ONA-A carries a black box warning for the potential of the botulinum toxin's effects to spread beyond the site of local injection, potentially causing breathing difficulties, visual disturbances, among other effects. Other unique warnings include the increased risk of clinically significant adverse events in patients with pre-existing neuromuscular disorders, and several indication-specific warnings related to uses other than for headache prophylaxis. For patients requesting to add a prophylactic CGRP antagonist onto their existing ONA-A therapy, Utah Medicaid prior authorization or PA criteria currently require the patient have a residual burden of at least 4 migraine days per month while on ONA-A therapy. This seems to be a reasonable threshold based on the goals expressed by the IHS, where optimal control is considered to be less than 4 days per month with migraine or moderate to severe headache, and the ideal but often difficult to achieve goal of 0 per month. Based on overall guideline recommendations, patients may be appropriate candidates for combination therapy if they continue to experience clinically meaningful residual migraine burden despite at least a partial response to adequate trials of preventative monotherapy, even if they are below the 15 monthly headache day threshold after monotherapy. Overall, experts encourage individualizing combination therapy, such as for patients with chronic migraine, as it is unlikely that any single prophylactic monotherapy will sufficiently reduce migraine or moderate to severe headache days to the IHS-supported optimal target of fewer than 4 per month. For patients requesting to add ONA-A onto their existing prophylactic CGRP antagonist, Utah Medicaid PA criteria currently require the patient to have a residual burden of at least 15 migraine days per month while on CGRP treatment. Notably, this requirement is more restrictive than the definition of chronic migraine, which requires at least 15 headache days per month, not migraine days, with migraine features on at least 8 days per month. So it appears that the nuance of headache days versus migraine days has likely been overlooked for this criterion. Additionally, this requirement does not consider the patient's baseline headache or migraine frequency, or in other words, their underlying disease burden, as the criterion is solely based on residual frequency. Overall, the PA criteria allow for combination therapy in patients with chronic migraine, but the ONA restriction can influence the order in which agents are added. For example, some patients diagnosed with chronic migraine with a residual migraine burden below 15 days per month, but greater than 4 days after CGRP monotherapy would have to then trial ONA-A monotherapy, potentially again, before being eligible for combination therapy. Overall, guidelines recommend considering combination therapy if patients have residual migraine burden of any number that significantly interferes with function or quality of life. The IHS specifically recommends adding ONA-A for patients responding to CGRP antagonist preventative therapy, but with residual migraine burden. Reviewed observational studies generally included patients with chronic migraine who had any number of residual headache days per month to warrant additional therapy. While experts recommend individualizing combination therapy according to the patient's needs, we recognize that the pertinent evidence for combination use is based on observational and single-arm pre-post studies at this point. Potential modification to the PA form for ONA-A could be to change the residual migraine day requirement to at least 8 days rather than 15 days, or alternatively use a less restrictive threshold for residual migraine considering overall guideline and expert recommendations. An option could be to require patients to have a history of chronic migraine diagnosis, along with at least 4 residual migraine days per month while on prophylactic CGRP antagonist therapy in order to be able to add ONA-A. Currently, the Utah Medicaid PA form for CGRP antagonists requires patients with chronic migraine to have tried and failed at least 3 drug classes before a CGRP antagonist can be used for prophylaxis. However, newer guidances from the AHS and CHS recommend CGRP antagonists as first-line options for headache and migraine prevention in patients with episodic or chronic migraine. And the AHS no longer recommends a requirement for prior failure of other drug classes before starting a prophylactic CGRP antagonist. Moreover, prophylactic CGRP antagonists are among a more limited group of treatments that are preferred for patients with chronic migraine. Thus, such criterion on the PA form may be considered for modification to a less stringent requirement, regardless of whether the CGRP antagonist is used as monotherapy or in combination with other prophylactic agents. This concludes the presentation. Thank you so much for your time and attention.
Thank you very much. I think we have a couple of things to consider there. Are there any board comments or questions?
Dr. Weinstein, I just wanted to say thank you so much to Monet and her team for this report. This report originally came as a topic idea for DUR because we noticed that there was a difference in the 2 PA forms for the CGRP antagonist for migraine prevention versus the form for the Botox for migraine prevention. One was more restringent compared to the other, and so that's why we wanted clinical, information from guidelines and other areas to see if we can make the criteria a little more loose and more in line with what's clinically recommended nowadays. And so that's why this report was produced for that purpose. Now, historically, Utah Medicaid doesn't bring back PA criteria when we're going to loosen it, when we're going to make it less restraining to the DOR board for a vote on that. That's historically how we've been doing things. We only bring the PA forms back when we're going to make it more restricting. And so anyway, I just wanted to say that before we start the discussion, because there's good things to discuss on this.
I appreciate that clarification. And if we don't need to take an action today, given that, I think we might still have some comments of interest from the board if there are any. I would certainly say to bring these forms in line, not only with the two forms between them, but also to update to our current clinical consensus. Like many things in practice, in the absence of some definitive studies, we still have a lot of experts having reviewed this, and where you can synthesize clinical expertise across the international community in headache, I think that's what we should follow. So that would be my 2 cents for this. Interested in what the other board members have to say. Dr. Brixton?
I would just say that I agree. I think the policy should be in alignment. The only caution, of course, is that this is a very prevalent condition, and I don't know what the procedure is behind the scenes to evaluate what the fiscal impact would be. But I would just recommend that that be done when this is considered.
Yes, Dr. Braden. So we would meet with our weekly PA meeting that we have with the team, with the Medicaid team. And then usually, you know, when we make revisions, we could definitely send those out to the ACOs to get their input, and then post the criteria. But we would definitely update the board on that too next month.
Thank you.
Thank you for that. Are there any other board comments or questions for today on this? If not, then we'll look forward to just being kept apprised of how this work proceeds. And again, appreciate all the effort and attention to rectify our own forms, as well as bring our standards of practice up to what is available. Great. I think we can move on to our next item. I'm just following the printed agenda, Luis. If we need to change it around, let me know. Looks like we have some public comments.
That's correct. Yes, we have 2 that submitted the conflict of interest form on file. So I also received, just so the board knows, I also received 2 letters emailed to me yesterday from different organizations. Unfortunately, I was not able to receive their conflict of interest form, which is required. And so I'm not able to read their content, but we will definitely discuss it among the Medicaid team. So yeah, so the first one looks like we have Dr. Kyle Knudsen.
Yep. Can everyone hear me okay?
Yes.
Yes, thank you.
Perfect. So my name is Kyle Knudsen. I'm a health outcomes liaison with Axsome Therapeutics. Thank you for the opportunity to provide information on Symbravo, which is a novel oral single-dose medicine approved for the acute treatment of migraine with or without aura in adults. Symbravo represents a multi-mechanistic approach to treating migraine that targets multiple pathways underlying the symptoms of a migraine attack. Symbravo consists of Mosaic, meloxicam, and rizatriptan. Mosaic is Axsome's patented rapid absorption technology. The Mosaic formulation results in an approximately 5 times faster median time to maximum plasma concentration for meloxicam while maintaining a long plasma half-life. Meloxicam is a COX-1, COX-2 inhibitor, non-steroidal anti-inflammatory drug with preferential binding to COX-2, and rizatriptan is a 5-HT1B, 1D agonist. In the pivotal phase 3 Momentum trial, a single oral dose of Symbravo provided rapid freedom from migraine pain and most bothersome symptoms at 2 hours post-dose, as well as return to normal functioning at 2 hours and sustained pain freedom through 24 hours. In addition, 77% of patients treated with a single dose of Symbravo did not use migraine rescue medication within 24 hours in the Momentum trial. Symbravo demonstrated efficacy across a broad range of migraine severity and in a head-to-head evaluation with its components. Of note, the FDA-approved labeling of Symbravo states that it is not substitutable with other formulations of meloxicam or rizatriptan, even if the milligram doses are the same or similar. This past February, results of the eMERGE trial read out. eMERGE was an open-label trial that enrolled migraine patients who were undergoing treatment with an oral CGRP inhibitor for at least 1 month and experiencing an inadequate response as assessed using the mTOQ-4. Enrolled patients were switched to treatment with Symbravo for their next 4 attacks. eMERGE met the primary endpoint by demonstrating statistically significantly greater migraine treatment response with Symbravo compared to treatment response with prior oral CGRP inhibitors as assessed by the mTOQ-4 total score. Statistically significantly greater proportions of patients achieved clinical response on the 2-hour pain freedom, sustained pain freedom, ability to return to normal activities, and ability to plan daily activities, mTOQ-4 items with Symbravo compared to oral CGRP inhibitors. The most common adverse reactions in the controlled studies were somnolence and dizziness, each being reported in 2% and 1% of patients in the Symbravo and placebo arms, respectively. As with all prescription NSAIDs, Symbravo carries a black box warning for risk of serious cardiovascular and gastrointestinal events. Please refer to the full prescribing information for a complete list of warnings and precautions and adverse events. In summary, Symbravo is a novel oral multi-mechanistic migraine treatment that addresses important clinical unmet needs and has shown efficacy in acute migraine, pre and post CGRP inhibitors, and should be considered for preferred status on the PDL for the Medicaid beneficiaries in the state of Utah. Thank you for your time and your consideration, and I'm glad to answer any questions you may have.
Thank you. Do we have any questions about Symbravo? If none, I think we'll move to our next public comment. I think we have Linda. Is Linda Finch on? Yes, please proceed.
Sorry, can you hear me? Sorry, I couldn't unmute there.
Good morning. We can hear you now.
Good morning. My name is Linda Finch. I'm a medical account director for Biogen, the manufacturer of Zurzuvae. Am I supposed to be testifying now or at a later point when we're reviewing that class?
We'd have your 3 minutes comment now, if you would, please.
Okay, sure. So Zurzuvae is currently the only FDA-approved medication for the treatment of postpartum depression since Zulresso was taken off the market last year. Zurzuvae is a Schedule IV controlled substance and has a boxed warning for impaired ability to drive or engage in other potentially hazardous activities due to CNS depressant effects that can last up to 12 hours after administration. I'll refer you to the PI for full safety information. So I want to share that the Utah Medicaid has a well-designed policy for access to Zurzuvae for women with this serious condition, and I'll share some reasons today to maintain that access. Postpartum depression is one of the most common complications of pregnancy, occurring more frequently than gestational diabetes. But in spite of this, PPD is currently underdiagnosed and undertreated. And women with PPD of any severity level are at a higher risk of suicidal ideation, and maternal death from suicide is a leading cause of maternal mortality nationally. So Zurzuvae is different from traditional antidepressants in many aspects. It has a novel mechanism of action targeting GABA A receptors. And in our trials, Zurzuvae patients achieved a remission rate of 44% and 53% respectively within 45 days of treatment. And this is a difference of 14 and 27% respectively greater than placebo. And this compares to a remission rate of around 3.2% when PPD is treated with standard of care antidepressants. So patients taking Zurzuvae in our trials experience statistically significant and clinically meaningful symptom improvement as early as 3 days after 2 doses of Zurzuvae. And this improvement was sustained out to 45 days after treatment. And we know that traditional antidepressants can take a minimum of 4 to 6 weeks to begin to show symptom improvement. So traditional antidepressants have been used in clinical practice for PPD, prior to the availability of the newer agents. However, they've not been evaluated in robust randomized clinical trials for PPD, and of course are not FDA approved for that use. And a Cochrane systematic review reported that the evaluation of evidence for SSRIs for use in PPD is characterized by studies with a substantial risk of bias due to high dropout rates, selective reporting, and small sample sizes. SSRIs have also been associated with a range of adverse events leading to noncompliance, and that may affect treatment outcomes. And we know about 60% of patients on antidepressants are non-adherent by about 3 months. So Zurzuvae may help address adherence challenges since it's just a brief 14-day course of therapy rather than a chronic therapy. And it's also been shown to be more cost-effective than standard antidepressants for the treatment of PPD. We know the timing of when PPD is treated is really critical to the well-being of a mother and her newborn. And according to the CDC's maternal
Sorry,
mortality.
Dr. Finch, that's time, 3 minutes.
Okay.
Thank you.
Okay, thank you.
Thank you so much. We will come back to those. I think next up on our agenda is to review some new prior authorization criteria. Is Dr. Fenton with us?
Yes, let me get this screen shared here.
Thank you.
All right, good morning. So the new prior authorization criteria that I'm going to present is, we titled it Novel and Multimodal Antidepressants, and it includes the antidepressants Auvelity, Fatsima, Trintellix, and Vibrad. Before I go over the criteria, I just wanted to kind of mention some of the context of like why this prior authorization was created. These medications currently, the Auvelity, Fatsima, Trintellix, and Vibrad, are all currently on the PDL as non-preferred. And that means in order to get them approved, a patient would need to like trial and fail something in the same PDL drug class as these medications. However, because antidepressants kind of span a bunch of different classes, currently it doesn't make the most clinical sense how it's currently set up. Like for example, Auvelity, it's categorized as a miscellaneous antidepressant, and the preferred miscellaneous antidepressants include like trazodone, mirtazapine, bupropion, etc. So someone could like trial and fail, you know, a bunch of different SSRIs and SNRIs, but because they hadn't tried like bupropion, they technically wouldn't currently meet criteria for Auvelity. So the purpose of this criteria is to kind of better align things with clinical practice, to do, you know, a bit more appropriate, as well as just align with the FDA indications of these medications. So with that said, fairly short criteria, but number one is all of these medications have a age indication of 18 or older. So we're just asking, is the patient 18 or older? They're all only indicated for major depressive disorder, so just verifying that diagnosis on number two. 3, does the requested dose align with the FDA approved labeled dosing, utilizing the minimum number of units necessary to achieve the requested dose? And then number 4 is kind of the main one we're trying to address here, which is, does the patient meet one of the following criteria? The first one being, the patient has a treatment failure of 2 preferred antidepressants from at least 2 of the following categories, each tried for at least 6 weeks, unless clinically significant adverse effects were experienced, or all were contraindicated. Excuse me, or all are contraindicated. That includes SSRIs, SNRIs, or bupropion. Or if the patient is new to Medicaid, have they been stable on their requested medication for at least 60 of the last 90 days? Kind of allowing them to, you know, continue the therapy that they've been on if they were on a different provider, and not have to, you know, prove their treatment history. Reauthorization criteria includes, have they shown a clinically significant improvement? And then just another dose attestation. Does the requested dose align with the FDA approved label dosing, utilizing the minimum number of units necessary to achieve the requested dose? And that's everything on that one. Does anyone have any questions? Yes, Dr. Britton.
I apologize if I missed it. Is 6 weeks an appropriate duration to adequately assess the effectiveness of antidepressant? That's
Sorry, the microphone was a little fuzzy. Did you ask, is 6 weeks appropriate to assess the treatment success of like these, like SSRI, SNRI?
yes, sorry, that's correct. Is 6 weeks an adequate duration to assess the effectiveness adequately?
Yeah, so from what I've seen, like the minimum should be at least 6 weeks.
Okay, because even most medications that we've seen, an adequate duration is generally, we say 90 days. But I just wanted to see what the other board members thought.
Dr. Britton?
I know that when I personally have treated patients with depression, of course, mine with younger kids, and that we usually are going to see some type of positive effect within a month. So I would think 6 weeks would be, I would think enough time, but I don't have the data to tell you for sure on that. But I would feel like if you're not seeing any movement in 6 weeks, that's pretty significant because usually we do see improvement before that if things are working. That's helpful.
Yeah, so any movement or somewhat positive movement, but full effect, like full failure, I don't know. I just wanted to throw that out there.
I also think like dosing too. And so is that, I mean, I know it's written in there, but is that going to factor into the, to if they qualify or not, because they could be on maybe an ineffective dose, but is anybody actually going to look at this and say, I don't know if it was effective or not?
And by that, I
Really
mean
good
like
point.
were they at like an optimized dose for at least 6 weeks?
Well, adequate dose and duration is necessary, which means, you know, what the therapeutic dose range for a specific drug is. If someone is only taking, say, 25 milligrams of Zoloft or, you know, 10 milligrams of Prozac, you know, as an SNRI, that is usually, or SSRI, excuse me, that's usually not adequate to, you know, address their treatment, or like 75 milligrams of Effexor per se. So you actually do need to have at least, you know, a therapeutic dose, or explain why they couldn't tolerate a therapeutic dose. And the different medications vary in terms of the amount of time necessary to actually see a response, but you first have to titrate to an effective dose, and then at that point, you know, see, you know, the range is sort of between, you know, 4 to 6 to 8, even sometimes up to 12 weeks, depending on, you know, the half-life of the medication and other factors involved in terms of, so I don't know that you'd necessarily want to limit yourself at 6 weeks per se, but you do definitely want to have a therapeutic dose, or explain why you were unable to titrate to that dose, and be a little more explicit in terms of, or at least give more information on the strength, the duration, and reason, you know, there was only partial response, no response, rather than sort of trying to create a, you know, a single criteria. It may need to be individualized based on the medication itself or the class itself.
Yeah, that all makes sense because it's not truly a treatment failure if someone is just staying at a subtherapeutic dose. Would it make sense to right here add, let's see, the patient has a treatment failure of 2 preferred antidepressants, and then we could add right here at, oh, let's see, maybe it won't let me add, but where the cursor is right now, at an adequate therapeutic dose language right there.
And duration. And
yeah.
yeah, and then I would remove the 6 weeks if that's getting to Dr. Siegfried's point, which I think we're all, observing clinically. The time frame for how doses get titrated, it depends on follow-up, depends on other things that may be happening. There may be more than one drug involved. So I think to limit it that way, I think if we say adequate therapeutic dose and duration, would that capture it?
And giving the details underneath would be more helpful for the, those who are reviewing the PA to understand, exactly, the specific medication, and then they'd be more able to evaluate whether it was an adequate dose and duration.
So we have that bolded underneath. Is that sufficient to say to include all that information?
You might want to say instead of dates, maybe duration, or you could say dates, either one. And it could be not necessarily failure. It could be, only, partial response.
So like treatment details or something like that.
Because it may not necessarily be a complete treatment failure. It may be a partial response or other treatment details explaining why you were unable to titrate to a higher dose because of side effects. You may want to change it to, something else where you refer to the chart or something that gives you more information.
Yeah, Dr. Britton.
So I don't know if this would help, but response details versus just treatment. Treatment might for someone mean, something different. For like a blanket statement on our prior auth forms, we always say you must submit clinical documentation. Otherwise, it could be denied. Do you have like a blanket statement like that?
I believe we do.
Okay.
I don't know if it's like definitively demanding it though, like fax form and relevant documentation, including.
Yeah, we say something like failure to submit
notes and
clinical.
Yeah, that makes sense. So adjusting this failure details to response details and adding adequate therapeutic dose and duration, and making it, and potentially adding something to make it like we need chart note details is what I'm hearing. Does that sound about right? Yeah, and I agree with all those, so we can get that edited.
I don't know if we need, excuse me, if we need a motion or we're all in agreement.
I would agree with those changes. I don't know. We need a vote.
We need to approve the revised PA form.
Yes, it would be great if we can get a motion, Dr. Wynn.
So we'll take a motion to approve as amended in the discussion.
I will make that motion then.
Thank you. Do we have a second?
I'll second.
You all in favor?
Aye.
Okay, thank you so much for that. I think we'll move on to our next item, another new prior auth criteria for Qelbree or viloxazine.
All right, good morning, everybody. So I have the pre-criteria for Qelbree. All right, is the patient 6 years of age or older? Does the patient have a diagnosis of attention deficit hyperactivity disorder? Does the patient have a history of the following? A failure, intolerance, contraindication to at least 2 preferred ADHD drugs from any of the below classes at a therapeutic dose with a treatment duration of at least 4 weeks. Those are methylphenidate, amphetamine, and non-stimulants. These are clonidine ER or guanfacine ER. And failure, intolerance, contraindication to atorvastatin with a treatment duration of at least 3 months. And for reauthorization criteria, has the provider submit an updated letter with medical justification or updated chart notes demonstrating positive clinical response. And then the initial and reauthorization are 1 year each. Okay, any questions?
Any input from the board?
I just want to comment that this medication is similar to Strattera
Yes.
chemically. However, the main sort of advantages of it are that it can be open and sprinkled for those with swallowing difficulties. And as opposed to the Strattera, which is sort of metabolized through 2D6. If someone is concurrently taking 2D6 inhibitors or is a poor metabolizer there, this medication might be preferred. And also, the third reason is that with the Strattera, you can get a lot of GI side effects even if you split the dose. So this might be, something that you could use for intolerance. Otherwise, there isn't really enough data, head-to-head data, to show it's better than Strattera itself or other medications for ADHD.
Very much appreciate your expert input there, Dr. Siegfried. Are we, is there any suggestion for the form itself? We need a motion to approve the form as written then, if there are no recommended adjustments.
I move to approve.
Oh, I'll second.
Right. Sounds like we've got a motion and a second. All in favor?
Aye.
Thank you.
Okay.
Okay, moving right along. We'll come to back to Zurzuvae. Dr. Wan?
Good morning, everyone. Can everyone see my screen? Perfect. So I have the prior auth criteria for Zurzuvae oceranolone. Is the patient 18 years of age or older? Is the medication prescribed by or in consultation with a psychiatrist or OBGYN? Does the provider attest that the patient has not received prior treatment with Zurzuvae for the current postpartum period? For the current depressive episode, has the patient trialed and failed or has a contraindication to conventional oral antidepressants, SSRI, SNRI, bupropion, TCAs, etc., for at least 6 weeks at up to maximally indicated doses, but no less than commonly recognized minimum therapeutic doses? Does the patient have a diagnosis of moderate to severe postpartum depression shown with a validated depression assessment score and require immediate use of medication? We asked that they provide the scale, name, and score. Was the onset of the current depressive episode during the 3rd trimester or within 4 weeks postpartum? And then we asked that they provide the date of onset. Does the provider attest that the patient is not currently pregnant? Is the patient less than 12 months postpartum with a delivery date? And then does the provider have a documented depression treatment plan, including psychotherapy following treatment? And then we have authorization up to 14 days per delivery. And then I do want to acknowledge that we can also adjust criteria 4 to match the language that we have adjusted for the multimodal prior auth that Dr. Fenton presented. Is there any questions or concerns?
I have a question, just kind of logistically. If the patient, I mean, they stop seeing their OB after like 6 weeks postpartum. So I think we may also want to put, oh, I guess it is say psychiatrist. Sorry, I missed that. I just saw the OB and GYN. So my bad. Thanks.
Raises a question for me. Are there family practitioners who would then pick up the patient? I mean, this is, this is primary care. So I'd be interested in, board comments if we're saying in consultation with the psychiatrist, is the treatment of postpartum depression maybe has different overlaps of who might be involved, but I wouldn't want to limit a prompt action by a primary care clinician, whatever their stripe.
I agree, especially where some family medicine physicians do OB/GYN work too. So we want to make sure we're not excluding those providers.
And really one of the uses of this drug is severe postpartum depression where rapid response is critical. So you may not have time to consult with a psychiatrist. So you may be dealing with primary care providers or other providers before you can even get a psychiatrist involved. The rapid action severity of the postpartum depression really drive use of this medication as more preferred than going a more traditional route of trying other antidepressants first.
Thank you for that. It's one of those clinical scenarios where timing is even more essential, right? So I'm not sure where in the form if we need to make a modification. Dr. Wong, where are we? Sorry.
Yeah, so for criteria 2 likely is where we want to adjust, I think from the board to include like a primary care physician as well. Is that correct?
Or practitioner or clinician, right? I mean, might be in family practice.
Yes, Dr.
Dr. Britton?
Well, I think it's saying it's being prescribed in consultation with one of those two. You wouldn't be consulting with a primary care provider about it. So it's just whether that criteria is appropriate in all cases is what I think is being suggested, right? a primary care provider, a family practice doctor could prescribe it. But what we're saying here is that we would expect that they had consulted with somebody that this is the appropriate treatment to go forward. Are there not like emergency hotlines that a prescriber could consult with, or is this truly a drug that a primary care doctor would be ordering without talking to with a healthcare professional, mental health care professional?
Dr. Brinton?
I mean, certainly, I think you'd hope that there would be that access to mental health care. My concern with the line is not the psychiatry part, but the OB-GYN part. It seems like this is assuming, I think, that you're someone in primary care who has this patient that's come to you, and you're not over their OB-GYN, and you're not over their mental health. And they want to make sure you're coordinating with those folks. But there are primary care doctors who are over the delivery of pregnant women, which would be family medicine. So I just think the OB-GYN by itself would need to be expanded if that's what we're going to do, or dropped if we feel like psychiatry is a helpful thing. So, you know, I'd love to hear from our psychiatry team what they feel about the psychiatry part of that. But OB-GYN itself doesn't cover, unless that presumptively does cover family medicine doctors who do OB-GYN. But since they often are the sole provider of the patient through the pregnancy and the delivery and then postpartum, it seems like if OB-GYNs who you want to talk with, then you also want to talk with that provider who did that, who might be family medicine, not OB-GYN. So I just want to make sure that doesn't exclude the provider for that patient who did all the OB-GYN care, but is not OB-GYN.
I think Dr. Siegfried?
Maybe instead of psychiatrists, put mental health prescriber, because psychiatrist sort of narrows, really narrows it to even, further, where you have other individuals that they might be able to reach out to, and maybe within their, like a primary care might have someone in their group that is not necessarily a psychiatrist, but is an APRN, or is, mental health prescriber, and that would be, perhaps more appropriate, and widen the scope of those they might consult with.
Yeah, definitely. I think that would be a reasonable change. Then Dr. Brinton?
I was just saying that first change with respect to OB-GYN, I'm not entirely clear on that. Are we saying OB-GYN and or PCP? But the PCP might be the prescriber that we're asking to consult with somebody. So I'm a little unclear. Are we saying the healthcare provider that provided OB-GYN services? What are we saying there?
Could we maybe adjust it to like a primary care provider that has been providing continuous care for the patient, something along the lines of that, and then add in the in-consultation with a mental health provider or OB-GYN.
Okay, so I think that the whole purpose of that, and you guys can tell me if that's off base, but the whole purpose of that line, I think, is to get somebody who has more training in providing mental health services, and in particular in women who are postpartum. So I don't know if that opening it up is too open blanket, but I defer to the mental health professionals on this board to determine that.
I think the question in my mind just follows that. Are we asking that a prescriber, if they're not a mental health professional, would be encouraged to consult with a mental health professional before prescribing this, regardless of whether they're OB or family practice, primary care. I think and this is really a question, probably more to Dr. Siegfried. I mean, do we think that making a consultation requirement is going to impede the care? And is it clinically necessary? We're not saying getting the patient to the visit, right? Because that we know could be significantly delayed. But just to suggest that if this is not a mental health prescriber, that they have discussed care with the mental health person. Is that what we're saying? They would need to discuss it before prescribing and show that they discussed it.
Yeah, otherwise I don't really see the point of that criteria too much.
Right. I was thinking the same thing, unless we're making that a requirement of non-mental health prescribers of this particular antidepressant. Dr. Britton again.
So I was just going to say, Dr. Siegfried, what do you think? Did you already opine as to whether it's appropriate for anyone to prescribe it without consulting?
Well, I definitely think that, you know, if you just have a primary care provider, they should consult with some sort of mental health prescriber, because this medication should not be used just for general major depressive disorder or for mild or even, you know, moderate postpartum depression. But in terms of, you know, specialists in women's health, you know, that may be within the scope of their practice, but and that may overlap with some individuals who are primary care providers or individuals who are, you know, especially if OBGYNs. So I don't really know how to sort of word that so that someone who is comfortable using this medication, it's within their scope of practice, but they're not a mental health provider, doesn't need to take an extra step or, you know, go through an extra hoop to get the medication.
So could we say in consultation with a mental health prescriber as clinically indicated, something like that? So we're suggesting it, but it's not a requirement. Is that valuable? Would that be valuable?
I think that would, and probably revisit utilization over time, just to ensure that it, again, isn't being used for, you know, just within, you know, because not just for general major depressive disorder or for mild to moderate, you know, postpartum depression, where, you know, it really, there are other things that could be tried first.
Dr. Britton?
I was just going to say, could we say with a psychiatrist or a provider who has experience treating postpartum depression? I don't know. Would that help?
I think we can also, with if like the criteria 2 is a little like misdirecting for like the prescriber, we can also get rid of it, given the rest of the criteria should enforce appropriate use of the medication. But I'm also up to any suggestion in terms of how to better phrase criteria 2.
Yeah, I think if we were to eliminate criteria number 2 And as reviewers, as PA reviewers, we would be looking for, like, say, criteria number 5, where it talks about the actual diagnosis and looking at a scale to make sure that that's included in the chart notes. And so just to make sure that the provider is prescribing it appropriately, maybe that would be enough.
Yeah, I'm inclined that, we can trust our colleagues to consult as needed when they're feeling like they're out of their scope. But the form itself does specify the diagnostic and clinical criteria. So as much as I'd like to encourage people to, consult with colleagues when they need to, I'm not sure we need to put it in the form. We might be able to just remove 2, and then, as Dr. Siegfried has suggested, look at utilization and make sure it's not being used inappropriately, which I think would be the routine monitoring. Dr. Siegfried?
And just for clarification on number 5, we don't want to be treating a rating scale result. We want more details in the chart notes as well, because rating scales alone don't actually, make a diagnosis. Just for clarification, a PHQ-9, someone could have a very high score, but then, when I go over it with the patient, they may not have interpreted correctly. This is just an example, or, it may be, quite different when I review it during the interview than when they fill it out in the waiting room, per se, just as an example.
Point very well taken. So that suggests a review of narrative and chart notes, and to include the scales that might be relevant. And I think if the board's inclined, we could eliminate 2. I guess we need a motion.
And then I just had a quick question on number 9, the documented depression treatment plan. Some people, do not want to utilize psychotherapy. So I don't know that you want to necessarily have to say that the plan includes psychotherapy. I'm not sure, just maybe just having a documented depression treatment plan following the use of the medication.
And then I'm happy to make a motion for number 2 to be removed, so that way we can see if people are in favor of that.
Okay, we have a couple of amendments to the criteria here. If there's no further discussion, we'll take a motion to approve the form as amended.
So moved.
Second.
Thank you. Have a second. Thank you. All in favor?
Aye.
Thank you for that robust discussion.
Thank you.
And achieving best care for this particular subpopulation.
So
We have one last item on the agenda. Luis, do we have time?
we have just about a minute left, but it'll be really quick, I promise.
Okay, we'll hold you to it.
All right, so here we go. Sharing Filsivez, which is birch triterpenes. I think that's how you pronounce it. But it is a medication for epidermolysis bullosa, or ED. And so the criteria here, number 1, just to label, and number 2 is the medication being prescribed by in consultation with the dermatologist. And reauthorization criteria: has the patient had clinically significant improvement in wound healing? Initial authorization up to 6 months, reauthorization up to 1 year. Any questions?
Do we need to move to approve it? Because I would move to approve it.
I'll take
Second.
that in a second. Thank you so much. All in favor?
Aye.
Aye. And
Excellent. Thank you so much.
appreciate the board's attentive discussion today and thoughtful inputs on behalf of our Utah population. Again, we're grateful for your service, and I think our next meeting's February the 12th. We will plan to see you then. I'll take a motion to adjourn.
So moved.
And a second. Thank you.
And Happy New Year.
Stay well. Happy New Year to all. Take care. We'll see you in February.